Now we have a radiology workshop. Dr. Corrie Bach from Mayo Clinic, a radiologist from Mayo Clinic, will give the talk.
Thanks to Dr. Go and Dr. Goyle for the invitation to speak to you today. I'll try to keep my eye on the time so that we're still able to have a break. I'm Corrie Bach. I'm a radiologist here at Mayo Clinic, Rochester, and I'm nuclear fellowship trained. So a lot of this talk will be focused on PET-CT. And we're going to discuss the imaging of Erdheim-Chester disease, including common findings, challenges, and mimics. So the objectives today are to recognize the most common imaging findings of ECD and also discuss challenging cases and mimics that we see on imaging. So this is a nice table comparing the different organ involvement of the histiocytic neoplasms, including Erdheim-Chester disease, Langerhans cell histiocytosis, and Rosai-Dorfman disease, and kind of want to focus your attention on a few areas. So in Erdheim-Chester disease, we all know the bones are the most common site of involvement, and those are going to be sclerotic lesions. And that's in comparison to LCH, which is going to be a lytic lesion, most commonly involving the skull, and then also RDD, which is also going to be a lytic lesion, in contrast to the sclerotic lesions in ECD. In ECD, we rarely see lymph nodes, so that's an important thing to mention. And then also in LCH, you're rarely going to have cardiac, arterial, and retroperitoneal involvement. And then in RDD, you're rarely going to have pituitary or diabetes insipidus as compared to that being pretty common in both ECD and LCH. So another nice overview of the key imaging findings or organ distributions that we see in these histiocytic neoplasms. As you know, the bones are often involved in ECD and LCH, along with diabetes insipidus. And then in RDD, you're going to have most commonly skin and lymph node involvement. So we'll go on a quick tour of the organ involvement in ECD and talk about some of the challenges in radiology that we have and also mimics, starting with the bones. So this is the most common site of involvement. The bone scan is a sensitive study. And as you see on the first image here, our whole body bone scan, we have increased radiotracer uptake, centered around the knees. Whole body PET-CT provides more information on the CT portion. We're able to kind of look at the bones a little closer and get more information from the CT portion. And it also provides, other sites of disease or organ involvement that we can see on a whole body PET-CT that we can't see on a bone scan. And we perform these from the vertex to toes because if you performed, your standard PET-CT is usually from the orbits to the thighs, you're going to miss, the most common location around the knees. So it's important to, perform these PET-CTs all the way to the toes. In the radiograph here, you can see, the most common site involvement with the osteosclerosis in the metadiaphyseal region, around the knees. Here's some more images from a PET-CT. You see coronal images of the lower extremities where you have those sclerotic lesions that are FDG avid. And typically these are epiphyseal sparing, but we have seen a few patients that have had involvement of the epiphyses, as you can see in the bottom image, where there's intense FDG uptake in the epiphyses. The axial skeleton is involved about 50% at a time, and you can also have involvement in the small bones of the feet that you can also see on the lower images. So the bones, even though they're the most common, they may not always be the first presentation of Erdheim-Chester disease. Here's a patient that in one of his first PET-CTs that we have here back in April of 2021, he, mainly had just renal involvement. There's, the hairy kidneys, some ill-defined soft tissue stranding around the kidneys that have some mild FDG uptake. And as you can see in his bones on this whole body MIP, there's, no FDG uptake in the distal femurs, and also on this coronal CT image, or axial or coronal fused image, you can see there's no sclerotic lesions and no FDG uptake in the bones. This patient was kind of on and off different therapies, and didn't tolerate some of the therapies. And so our next PET CT, he had a little bit of progression of disease. You can see now that there's a little bit more FDG uptake surrounding the kidneys here. And then he has developed sclerotic lesions in the distal femurs that are mildly FDG avid. So we've had a few patients where the bones haven't been the first site of presentation. Next, we'll move on to some mimics in the bones. This patient had enhancing brain lesions and polydipsia, so there was suspicion for Erdheim-Chester disease. They underwent a FDG PET CT, which demonstrated some mildly FDG avid lesions in the distal femurs. As you can see in his radiograph here, it probably doesn't project really well, but there's these tiny lesions in the distal femurs that kind of have a ring and arc calcifications, or sometimes we describe it as popcorn calcifications, that you can see here, down here in the coronal and axial images of the distal femurs, and really mild FDG uptake. So this is a better look for enchondromas, which are a benign cartilaginous lesion. And so they can have a similar distribution, because they're pretty commonly found in the metadiaphyseal region, but they're not the typical sclerotic lesions of ECD. This patient is a 40-year-old male. They had suspicion for ECD by the outside facility, and he underwent a whole body bone scan, and which demonstrated radiotracer uptake about the knees and also the proximal left femur that's outlined in the green boxes. Next, he underwent a whole body FDG PET CT, and those areas demonstrated non-FDG avid, tiny punctate sclerotic foci. So this is a better look for osteopoikilosis, so just kind of benign bone islands. And these are often seen around the joint area, so you can see them around the knees pretty commonly. And so again, it's a similar distribution to the most common ECD findings, but they're not the typical sclerotic lesions. This is a 67-year-old female. She had an incidentally discovered sacroiliac lesion on FDG PET CT that you can see pointed in the blue arrow. There's a mildly FDG avid lesion in the pelvis there. And on the oblique coronal image of the sacrum, you can see the FDG avid lesion in the right sacrum. And then here's a corresponding MRI showing some heterogeneous enhancement. She underwent an outside CT guide biopsy, and it showed some features that, they had a presumed diagnosis of ECD. She then underwent she was BRAF negative, so she underwent next generation sequencing. It didn't reveal any MAPK or mutations. And so this led to a rebiopsy, and it showed a histiocytic infiltrate, but it was negative for factor 13A. So both the histopathology and the radial findings supported a diagnosis of fibrous dysplasia. And so this was a single osseous lesion that we saw on her PET CT. It was lytic, it was not sclerotic, so it didn't have the typical features that we would see with ECD. This is a 33-year-old female. She had progressive fatigue, weight loss, right pelvic numbness that radiated down her right leg. And on her pelvic radiographs here, you can see outlined in the circle is a lytic lesion in the right sacrum. Here's some of her outside MRI images that you can see, the lesions centered in the right sacrum, but it also involves the right iliac bone here as well. She underwent an outside guided CT biopsy, and the outside report said it was consistent with ECD. It was positive for CD68 and factor 13A, and negative for BRAF. She subsequently underwent a whole body PET CT, and this was the only lesion that was identified on her PET CT, and it was a lytic lesion, again, located in the right sacrum, but it also involved the right iliac bone, so it's kind of centered along the right SI joint. And as you can see, it's pretty intensely FDG avid. So these findings didn't really go along with the suspicions for ECD, so they re-biopsied it, and the biopsy results combined with the findings that that's a lytic lesion centered on the joint. It supported a diagnosis of tenosynovial giant cell tumor. And so again, lytic lesions are not characteristic of ECD. And then our last osseous mimic, this patient had an outside mesenteric biopsy that they said showed some foamy histiocytes, so they were suspicious for Erdheim-Chester disease. They came to us and underwent a PET CT. As you can see in this axial image here, there's small mesenteric lymph nodes, a little bit of ill-defined hazy stranding in the mesentery, but nothing that's very remarkable. And then in her bones, in the distal femurs, she had these lesions with low-level FDG uptake. They kind of had some peripheral, more like serpiginous sclerosis. And I think even the initial read thought it was suspicious for ECD. This was, re-reviewed with some of the radiologists in the histiocytic working group and also an MSK radiologist. And this is a better look for bone infarcts. And so these are commonly found in the distal femurs. So it's a similar distribution, but again, it's not our typical kind of irregular sclerotic lesions that we see with ECD. So some of the mimics that we kind of went over, different sclerotic lesions can be mimics for Erdheim-Chester disease, such as enchondromas, osteopoikilosis, bone infarcts, and then also different FDG avid disease can be mimics as well. Showed a case of fibrous dysplasia, tenosynovial giant cell tumor, Langerhans cell histiocytosis. That's going to be a typical lytic lesion, most often in the skull that you can see here. And then also Rosai-Dorfman disease, which is going to be a lytic lesion. It can often have a predominant soft tissue component to it as well. So moving on from the bones to the retroperitoneum, we're going to talk about the kidneys next. This is commonly involved where you get the hairy kidneys that you're all familiar with, where you have the bilateral perinephric soft tissue stranding. As you can see on the images on the right here, you have, pretty moderate FDG uptake surrounding the kidneys here, corresponding to the soft tissue thickening that we see on this contrast enhanced CT. The contrast enhanced CT is going to help identify some of this thickening a little better than it can. Sometimes when it's subtle, it can be missed on the PET CT. So besides the perirenal involvement, you can also get renal sinus involvement, and this can sometimes lead to obstruction of the proximal ureter and can lead to hydronephrosis. In the bottom image here, you can see this ill-defined stranding in the renal sinus, and also on this right image here, you have involvement of the renal sinus, and this patient actually has bilateral ureteral stents in place. It can also extend into the adrenal fossa, as you can see in this FDG avid lesion in the right adrenal fossa. And then here's another example of a pretty moderately FDG avid involvement of the retroperitoneum bilaterally. This is a 57-year-old male, and so he had perirenal soft tissue stranding. So Erdheim-Chester disease was suspected. But as you note, he also has splenomegaly outlined in the yellow brackets and also had pretty extensive lymphadenopathy, both above and below the diaphragm, as you can see outlined in the blue boxes. So when you have splenomegaly and lymph node involvement, other diagnoses should come to mind as well. And this is biopsied and shown to be lymphoma. So just remember that lymphadenopathy and splenomegaly, they're pretty rare in Erdheim-Chester disease. This patient had perinephric and periuteral soft tissue stranding that you can see on this contrast enhanced coronal CT image. Pretty prominent soft tissue strand or soft tissue mass in the proximal ureter that's obstructing it, as you can see a ureteral stent in place bilaterally. Sometimes this can be challenging to see on the FDG PET CT because you have such high physiologic FDG activity in the urine. So as you can see, all this, bright reds is just urine activity, but there is some FDG uptake in that soft tissue component. And he also had mildly FDG avid retroperitoneal node as well. So the outside kidney biopsy was non-diagnostic with inflammatory cells. So this retroperitoneal node was then targeted for biopsy, and that demonstrated Rosai-Dorfman disease. So Rosai-Dorfman disease can be a mimic with renal or periuteral involvement when there's also lymph node involvement. So remember that lymphadenopathy, again, is rare in Erdheim-Chester disease. So some of the mimics in the retroperitoneum that we talked about was lymphoma and RDD. Other things to consider is IgG4 related disease or idiopathic retroperitoneal fibrosis. Typically that usually is thought to spare the posterior aorta and more often involves the mid to distal ureters. So next, moving on to the nervous system. Can have a variety involvement in the nervous system, can have parenchymal lesions, most commonly in the posterior fossa, can have either multiple or solitary dural lesions or just diffuse thickening of the pachymeninges, and also spinal cord involvement, either intra or extramedullary involvement. And then, the neurodegenerative changes or atrophy as well. In these images on the right here, you see intensely FDG avid dural masses and some thickening. And then here's some images of intensely FDG avid spinal disease corresponding to this, enhancing epidural spinal mass that you see here. Also nerve root involvement, we often see on PET CT as well. As you can see, these mildly FDG avid lesions by the lumbar nerve roots. And depending on the presentation, there can be a lot of different mimics. Neurosarcoidosis can be considered. If there's dural-based lesions, meningiomas can be mimics. Different malignancies or carcinomatosis, and LCH and RDD can also have nervous system involvement. And then, along with the nervous system, as we talked about earlier today, diabetes insipidus is pretty common, where you get involvement of the pituitary gland. You can get infiltration of the hypothalamus and pituitary. You get the loss of the normal posterior T2 bright spot. And then the normal pituitary imaging doesn't exclude, a hormonal deficiency. Sorry about that, it just jumped on me. And so here's some images. On FDG PET CT, sometimes I think the pituitary gland is often overlooked. On axial images, it can be hard to see, but with involvement, you can see some increased FDG uptake that's, better appreciated on the sagittal images, but the brain overall is pretty challenging at times to evaluate on PET CT just because of the high physiologic brain activity. And so MRI is, a lot better to evaluate the brain. As you can see on here, there's, thickening of the pituitary stalk and the pituitary gland itself. In more mass-like thickening of the pituitary stalk here. Moving on to the lungs, the involvement of the lungs is pretty nonspecific on PET CT and CT of the chest. Commonly, you get like pleural involvement or pleural thickening, as you can see in the top images, intensely FDG avid pleural thickening. And then you can get interlobular septal thickening, but can also have just multifocal ground glass opacities and nodules in the lungs, as you can see on the bottom images. There's intensely FDG avid pulmonary opacities bilaterally. Sinus wall involvement is pretty common. In the maxillary sinuses, you can get involvement. In this first image is from a bone scan, where we see increased radiotracer uptake along the maxillary sinuses. And then these other images are on PET CT, where we have FDG avid mucosal thickening of the both maxillary sinuses, and you get this thickening of the maxillary sinus wall as well. And that thickening, it can be seen with just like chronic sinusitis as well. So in isolation, it's not, a specific finding for Erdheim-Chester disease, but when we do see it on our PET CTs, we can suggest it, that there is involvement. Moving on into the arterial system, commonly you see this periarterial fibrosis along the aorta. If it's sheathing in the entire aorta, it's sometimes called the coated aorta. And on these images here, you see intense FDG uptake surrounding the aortic arch. And then on the contrast enhanced CT, you're better able to appreciate the soft tissue thickening as compared to our non-contrast CT as part of the PET scan. This can involve the aorta, the aortic arc branches that you see in this first image here. This thickening going up the aortic arc branches can be seen in the abdomen involving the celiac and SMA artery and the renal arteries. This image here, you see the diffuse thickening surrounding the SMA branches, and then bottom image, surrounding the renal arteries. And then this last image showing some coronary artery involvement as well. Some mimics that we can see on imaging, vasculitis, that can be FDG avid on PET CT as well, usually diffusely, circumferentially involving the aorta. And then also atherosclerotic disease can also be a mimic on PET CT as well. Typically that's more patchy, and you'll often see calcifications along with it. And then moving on to the cardiac, you can see some intensely FDG avid pericardial infiltration or also effusion. And then you can get myocardial infiltration as well on PET CT. Normally, the cardiac has physiologic FDG uptake in the left ventricle, so that is often physiologic, but on this patient, we also see some intense FDG uptake surrounding the right atrium that is suspicious for Erdheim-Chester disease. And most commonly, it's going to involve the right atrial pseudo tumor appearance that you can see here, where there's intense FDG uptake in the right atrium area. And MRI is, great at evaluating cardiac involvement. As you can see here, this enhancing lesion corresponding to the area of FDG uptake. And one of the last main organ systems I'm going to cover is the orbits. You can get infiltrating soft tissue. It's usually in the retroorbital region, but it can be multi-compartmental. And this can be challenging to evaluate on PET CT alone because you get physiologic FDG uptake in the extraocular muscles. So it's really helpful to have, to pay close attention to the CT images where you can see all this soft tissue that's abnormal. But if there's, a dedicated MRI, that's always more helpful for us to compare to the PET CT. Here's a few other examples that are more prominent where you have intense FDG uptake. Um, this most likely wouldn't be missed on a PET CT. And you have pretty diffuse soft tissue in the retroorbital region. And then an example of a multi-compartmental involvement in the orbits. It was a 41-year-old female. She had progressive irritation and proptosis of the eyes. She underwent an MRI of her head. As you can see in the images on the right here, there's diffuse enlargement of the extraocular muscles and the lacrimal glands. She underwent an orbital biopsy that showed a histiocytic infiltration. It was BRAF negative, and there was suspicion for Erdheim-Chester disease. So she underwent a staging PET CT, as you can see here in the top arrow, showing the intense FDG uptake involving the orbits that you can see here corresponding to the findings on MRI. She also had some thyroid nodules that were FDG avid, and then in the groin here, this is a lymph node that's FDG avid. So this was suspected to be Erdheim-Chester disease. She was started on interferon alpha with no response, and also went on cladribine with progression of disease. And so at this point, then her diagnosis was re-reviewed, and pathology demonstrated IgG4 was confirmed on immunohistochemistry. And that kind of goes along with the imaging findings that we see here. The only site of involvement is the orbits. These thyroid nodules were kind of incidentally noted, and the lymph node, I think, had improved. So that's an example of IgG4 related disease. And so on imaging, there was really no other findings to suggest Erdheim-Chester disease. Just a few other sites to quickly touch on. The skin, we don't usually image too much. Typically, it's a clinical. You guys see that clinically. We can see some mild FDG uptake in some of the regions involved. The testicles can sometimes have increased FDG uptake if they're involved. And I think sometimes this is often overlooked. Typically, the testes can have physiologic mild FDG uptake, typically around 3.7 SUV max, but that can vary a little bit with age. And then on this bottom example, you see some pretty FDG avid involvement of the spermatic cord. Other rare sites of involvement, the liver. Here's an example of a FDG avid lesion in the posterior right hepatic lobe. That's pretty nonspecific, but in the setting of other findings of Erdheim-Chester disease, it can suggest involvement. And then also in this patient where there's peribiliary FDG uptake, and then also some FDG uptake surrounding the pancreas here as well. This is an example of a patient that had breast involvement. So in isolation alone, this would be more suspicious for a breast malignancy. But this patient had, I think, biopsy-proven involvement of her breasts. So we kind of went on a quick tour of the different organ sites of Erdheim-Chester disease, findings on imaging. The vertex to toes is very important to include all sites of involvement, and a FDG PET CT is helpful, to evaluate for the diagnosis, evaluate the extent of disease. It can help guide a biopsy site and also show response to therapy. And besides FDG PET CT, as you all know, brain MRI is really important, and cardiac MRI as well. And we reviewed a few mimics that we see on imaging, such as lymphoma, tenosynovial giant cell tumor, different FDG avid lesions. And then also other osseous lesions, surrounding the knees, such as enchondromas, osteopoikilosis, IgG4 related disease involving the orbits, and then also Rosai-Dorfman disease. So thank you for your attention.
Great presentation. Thank you. In the vascular involvement of ECD, do you have any clustering? I'll use the term clustering, meaning, do you think the involvement affect the aorta, infrarenal versus suprarenal, and it goes all the way down to like the iliac arteries, or it doesn't? Do you have any distinction? And
I've seen various presentations. I mean, I've showed a few presentations where involved, the aortic arch, but I've also seen, both diffusely throughout the abdominal aorta as well. Also, it can also have seen cases that extend into like the iliac regions as well. In my experience, I haven't really seen like a predominant involvement of the aorta.
thank you.
Yeah, a nice overview. I think there are two important differential diagnoses. Also, you could mention one for bone is Schnitzler syndrome, as you can have avid lesions of the long bones, and of course you have some monoclonal components, IgM and urticaria. And it's interesting because it's very sensitive to anakinra. So I had one case like that, and I think it was already published. And the other important for retroperitoneal is extramedullary hematopoiesis, which has been recently published, and have been confronted to such cases where they were discussing renal transplant and whether it was ECD or not. And the patient was biopsied first, and it was not ECD, and it was extramedullary hematopoiesis, and re-challenged for biopsy, and it was the same histology. So I don't know.
Great, thanks for bringing up those additional mimics.
Hi, Corrie. Thanks for a wonderful presentation. Two questions for you. One question is, you brought up a great description of the mimics of ECD in those cases. How frequently in your radiology report do you put ECD in the diagnosis or in the differential diagnosis, especially when it doesn't meet the classic bone findings? Would you ever put ECD in your report? That's number one question. Number two question is that, I had a patient with questionable osteosclerotic multiple myeloma, and it's like a diagnostic dilemma, especially when it comes to the biopsy, because we just couldn't pick up a clonal plasma cell neoplasm. But the question comes, is it a ECD versus osteosclerotic multiple myeloma, especially when it involves multiple bones? Are there any radiological cues to distinguish this?
To touch base on your first question, how often, I put ECD in my report when bones are not involved. I think it depends on, the imaging that's being performed. If it's, I also read abdominal imaging as well. So if it's, an abdominal CT, with, perirenal infiltrate, I think it's, appropriate to include ECD when you don't necessarily know if the bones are involved. On a whole body PET CT, I think it's, if I didn't see bone involvement, I saw, and it came in as a clinical suspicion of Radiology disease, I think I would still include that, whatever organ involvement could be seen with Radiology disease, or, what other additional differential diagnoses would go along with that as well. I think it would still be important to, put that on the differential, even without bone involvement, because as we've seen, one of the cases I showed where bone involvement may not be the first presentation, it may show up later, even though it's the most frequent organ involvement.
And my second question of osteosclerotic myeloma versus ECD, do you have any clues to how we can distinguish it radiologically?
I think the pattern of involvement, I haven't seen osteosclerotic multiple myeloma to be kind of focused around the knees. So if it's, the sclerotic lesions are focused around the knees, that would, be more suggestive of Erdheim-Chester disease. But if it's just kind of, scattered involvement of the vertebral bodies or elsewhere, I think it can be more challenging. So, looking for other sites of involvement would be helpful.
If I can ask a question, in your experience reviewing PET CTs for ECD patients longitudinally, do you have any sense of sites that maybe are more likely to resolve as opposed to not? I'm in my sort of informal, to the extent that I spy on the PET CT reports, I feel like the orbit improves, but kind of doesn't resolve, can be kind of stubborn, and maybe sometimes bone lesions don't resolve, whereas perinephric ones do. So this is all, informal. I'm wondering if you have any experience with what tends to improve more than others.
I don't have anything from my experience that, I've seen that says, different sites improve more than others. I'm sure as clinicians, you guys have probably seen it more frequently, but nothing comes to mind offhand.
Yeah, that was a great talk and really insightful. My question was, do you have any thoughts on thyroid infiltration and adrenal gland infiltration in this disease? And specifically, have you looked at it in terms of its burden in Erdheim-Chester as well as other histiocytosis?
Most often, we've seen adrenal involvement about 30% of the time. I think frequently we see it when it's, also involving the perirenal involvement as well. So I don't know if it's, it could be a progression of the disease, it starts off perirenal and then kind of goes adrenal. I don't know for sure, but that could be
That's interesting you mentioned it because, I think I mentioned this earlier because one of my colleagues also showed about a 35% prevalence of involvement. So I think that's something that probably needs to be further investigated in terms of its hormonal effects.
Mhm.
Thank you.
Sorry. Hi. Do you see any difference in sensitivity between the bone scan and PET CT for bone involvement? Because I had a few cases that had a very weak or absent uptake on PET CT, but they were avid on bone scan. Just for the bone, of course.
Yeah, I've seen a few cases of that as well, where you kind of see, more prominent rear tracer uptake on the bone scan. And so maybe that's more sensitive and you see that first, and then you kind of, once you develop kind of the sclerotic lesions, then you get more FDG uptake on the PET CT. I've seen a few cases of that as well. Yeah.
We did see some neuropathies, but we were never really convinced whether this was ECD related or not, though we speculated it would be such. So my question is, have you seen, how frequently do you see that in ECD, and do you see involvement on imaging of the peripheral system? Let's say it's excluded. So we really don't talk about that anymore.
I haven't personally seen any peripheral involvement. I've only seen the nerve roots, and it's not as frequent as other sites of neural involvement. I don't know the exact frequency, but it's less frequent than the other sites of nervous system involvement.